Julie Altman. There we go. I'm Julie Altman. I'm a clinical ethicist, professor in family community medicine, dean of our College of Graduate Studies here at Neomed. Allie, I sit on your board for Direction Home and part of the ethics committee. So if you're interested in ethics and sitting on your committee, do a little self-recruitment there. So it's nice meeting everyone online. And as new people pop on, just feel free to give them my contact information. So let me share my slides. Can everybody see those? Okay. So for some of you, this is going to be a kind of refresher on the main ethical principles. But what I really want to go into is a different approach that had started in the 80s and 90s with a care approach, a care ethics approach. And I'm going to talk about how we really need to start integrating more of the person-centered care ethics and not strictly just our rules and principles and some of the traditional ethics that you see on, say, social work exams, board exams, your autonomy, beneficence, and so forth. And so I'm going to take a dive into person care ethics. And we're going to be utilizing a case. Actually, I had a case a few years back, actually back 2013, that really illustrates both of the principle-based ethics, but also the importance of bringing a person-centered care approach in. So we're going to be talking through that case, and feel free to chime in, ask questions. I hope that it's not just me talking at you, that you have some opportunity for just bringing your own perspectives into this. So just as a kind of a refresher, this ethics toolkit, and I know some of you are getting CME for your ethics portion today. And so we're going to talk about some of the values, theories, principles, and decisions. These are the 4 components of ethics and how decisions are guided, not necessarily made, but guided through ethics. And we're going to use a case study of delusions of parasitosis. In fact, parasitosis, I was talking to Nicole a little bit earlier, that this is a condition in which an individual believes that they have bugs or parasites that are attacking their skin or other body parts, and it's they don't exist, the bugs don't exist, and it's a challenge in family medicine practice, pediatrics, dermatology. We're going to talk about dermatology. This is definitely an integrated care type of case where it can be a challenge of diagnosing, treating, and why a care ethics approach is definitely needed for that. So just a refresher, I always like to start out of what exactly is ethics. Oftentimes I do find that individuals think, oh, ethics is the law or these rules that you have to follow. And we typically use a prescriptive language in ethics where we should or we ought. It's not about law. It's not about these rules in terms of that we must follow. It's actually the study of morality and of moral values that we all bring to the table. And those moral values will vary among cultures, families, communities. And even though in medicine and healthcare in general, we try to identify those core moral values that we share, such as the value of, say, autonomy, or the value of fulfilling our commitments to patients. It can diverge based on a person's cultural perspective and their moral upbringing. And so ethics is studying those values and trying to derive at least a framework for developing those ethical rules and ultimately best practices or best decisions and actions at the end of the day. So where individuals oftentimes confuse ethics and morality is like, well, I believe this versus what my colleague or my patient or my friend believes. And so it's not about ethics is not about the belief system, but how we're framing those particular moral values for us to make sense, to operate, to support elements of justice, to be fair, and to consider the nuances of individuals. Our ethics toolkit does start with the foundation of values, of where our theories and principles originated, of what is meaningful to us. And oftentimes when we run into situations, ethical situations, it is a conflict of values. We want to promote good, we want to take care of our patients, but at the same time, the patient may not want the particular treatment that we offer. And so oftentimes the values in healthcare in particular is what our perspectives are versus our patients. And from a care approach, from a more of a person-centered ethics, we're trying to move away from this us versus them, or this value versus this value. It's more complex than strictly here's these challenging, conflicting. The theories and principles that I'm going to be presenting today, I'm going to be presenting actually 6 different theories, 3 of which have been traditional, that have actually given rise to what many of you recognize in the clinical world of clinical principles: your autonomy, beneficence, non-maleficence, and justice. But we're also going to be talking about those person-centered theories on virtue, care, and actually a narrative approach to medical decision making. Decisions that arise from our analysis of these theories and principles guide decisions. As a clinical ethicist and in a variety of different community-based and hospital-based environments, the bottom line is that we guide decisions, we offer perspectives, we give justifications for those perspectives, but we do not force a decision. We don't tell healthcare professionals what to do. We just offer that ethical reasoning and deliberation. And so when we run into really complex cases, it's not always a one size fits all. Despite the fact that you have ethics textbooks and multiple choice questions out there in the world that you have to fulfill, when you really get into challenging ethical cases, it requires a lot of ethical reasoning and deliberation by using a variety of these elements within the toolkit. And we're here to just basically present those and offer some support to ultimately your decisions as social workers, as physicians, as caregivers, both within your family and with patients. There's a whole host of different frameworks and approaches. This is just a speckle of what is out there, but what has guided, particularly in the healthcare field. You guys are going to be most familiar with principlism, your 4 principles that continue to be a prominent fixture in the healthcare setting. But as you see throughout time, casuistry, case-based, looking more at virtue, or looking more at feminist care ethics and narrative ethics, the elements that I'm presenting to you guys today are going to be challenging those older perspectives and frameworks where the principles alone are not going to help with every decision and offer very little in terms of guidance. Where we're seeing the value in actually more complex cases is with the feminist ethics, care ethics, narrative ethics approach, in addition to some of these older frameworks. And so just as a refresher for those of you who are familiar with the principles, or this may be new content for you. But going back to 1979, when the American Medical Association, as well as a variety of different healthcare organizations, really embraced this notion of principles. Principles think of them as more of a shortcut to those theories, those theoretical approaches, where not everybody is going to be contemplating and being philosophical in the healthcare field. They need a really quick way to help guide ethical decisions. And so the emergence of these principles actually came from foundational theories, but it was a quicker way to understand some of the, I don't want to say universal, but more universal values within the healthcare field, at least with the American-centered or North American-centered approach. So autonomy, the self-determination, examples are the informed consent process, beneficence, basically to promoting good. We see beneficence when you're challenged with treatment options or diagnostic procedures. You're weighing the risks and benefits and offering those risks and benefits to your patients, to your clients. The old adage to do no harm, right? That actually stemmed from virtue ethics, and that became the principle of non-maleficence, where it's the focus on avoiding or preventing harms. Non-maleficence became really critical in the legal field, healthcare legal field, particularly when we start looking at liability and connecting ethics, the intersection of ethics and law. And then there's justice, which is actually quite a broad field. Justice theory in itself is one of the broadest fields in ethics. And so when we've narrowed down to a single principle of justice, we talk about fairness, equity, inclusion, fair distribution of benefits and burdens, the avoidance of discrimination of our patients in the clinical setting. But just to let you guys know, justice is a broader field. It's actually a full field of study within the world of ethics. And then one that is not part of Beauchamp and Childress's four tenets, but is a principle that you do find in various capacities, particularly in medicine, is veracity. And this is the principle of truth-telling, being honest, disclosing, which is also part of that informed consent process. And where veracity became really critical in the 90s and early 2000s was actually with nursing students and medical students. When they're in the clinical setting wearing the white coat and the patient goes, "Hey doc, can you give me this particular piece of advice?" And representing oneself honestly was a charge that we offered our learners, saying, "Hey, I'm student physician so-and-so, or I'm student nurse so-and-so," so that the patient recognized that here's a learner, here's somebody who's emerging as a healthcare professional, but they may not have the tools, the resources, the knowledge and skills quite yet to answer some of those more complex questions. And so representing oneself honestly became a really critical principle, particularly for medical education and nursing education. AMA Code of Ethics, just as one body of literature, every field has codes of ethics, whether you're in social work, nursing, the specialties within your fields, psychiatry has their own, APA has their own codes of ethics. I'm using AMA as just an example of this. And so you'll find additional principles such as the best interest standard or substituted judgment, principle of double effect. All of these principles are kind of the ethical rules, if you will, that have been vetted, supported over the years by healthcare professionals and give better guidance to those ethical situations that are not as complex that we see on a day-to-day basis. And we have policies, legal laws, and procedures that kind of stem from these foundational principles. So when I talk about principles, keep in mind it's a much broader literature. But to use the foundational four from Beauchamp and Childress gives us a good basis for why our ethical decision-making has grown to be even more complex. So where did these principles originate? Well, they originated from old white dead male philosophers, okay? And we have John Stuart Mill, we have Immanuel Kant, we have John Rawls. We have these wonderful minds out there that really examined not just the fields of healthcare and politics and law, but they really looked at uh, how people behave, how they're thinking cognitively through these various problems, and why certain approaches may lead to better outcomes or better decisions. And so the three general areas of those traditional ethical theories from the 1800, 1900 philosophers are what is known as the doing theories. These were the theories that emerged as these are our right actions, these are our wrong actions, and here's the justification why. And they gave rise to these rules, such as autonomy, such as to avoid harm. And so when you look at these types of theories, and I put them in three different categories: goal-based, duty-based, and rights-based, all three of which are entering and have entered the healthcare field. So for example, when we're thinking about mandating vaccination programs, right? We think of oftentimes utilitarianism. We need to maximize the greatest good for the greatest number. We want to eliminate disease, and by doing so, we should have a mandate or a vaccination program. We typically see this type of approach in public health research, ways that we're looking at populations. Well, then our rights-based and duty-based theorists were saying, hey, John Stuart Mill, you came up with this utilitarian approach, but now you're ignoring the individual and the values of an individual versus a population. And so where we see very heavily ethics at the bedside are based on duties and rights. So the rights of a patient, such as privacy, looking at the duty of a healthcare professional to support those rights. So for example, rights and duties go hand in hand. As a healthcare professional, I have the duty of non-disclosure to uphold the right of my patient, which is privacy. And so when you look at rights and duties, it's about this relationship between upholding those fundamental rights and our obligations to do so. Well, this wasn't necessarily enough, especially as cases started getting more and more complex. And the AMA Code of Ethics, your Beecham and Childress principles, those are centered on these duty-based and rights-based approaches. And so we're going to look at those approaches, but we're also going to pick out why it's not enough. And so here's a particular case study. I actually had this case, worked with a interprofessional team of dermatologists, at the time a medical student who's now director of dermatology, and family medicine docs to really address this particular situation. So here we have a 55-year-old patient. She does present to the dermatology office, but you can imagine this type of patient can show up at family medical practice, a small clinic, at home. So I'm thinking of direction home, where you may be going into the patient's home. So it's aside from the dermatology office, she's showed up. The healthcare provider has offered and provided multiple biopsies, blood work, and there's no evidence of a parasitic infection or other primary disease. Okay, so think of this person as having this relationship with the provider over time, where doing a variety of diagnostics. Her symptoms have waxed and waned, but now she's coming in with this severe flare. And now she's like, okay, I'm going to start using industrial strength insecticides. In fact, the case that we actually had, they started purchasing industrial strength insecticides. Keep in mind, this patient had open wounds. There was overlying crust, arrhythmia, tenderness. There was constant scratching, and so those open wounds were quite there. So the provider's like, oh, we cannot use industrial strength insecticides on open wounds on your skin. And the provider came to the diagnostic conclusion that this was a case of parasitosis. And interesting enough, this was probably the third or fourth case in the provider's time that they've seen this type of situation. And so the provider talked about psychiatry as a support system for addressing this particular quote unquote skin infection. And the patient said, I don't want to see a psychiatrist. I'm not crazy. Why would I go to a psychiatrist for a skin infection when you can do another biopsy or give me some medication? And in fact, this patient did demand for another biopsy, and the provider was very concerned about having additional biopsies that could do some harm. So that's the background of this case. And at first glance, some of the ethical principles and traditional theories, so just thinking about Beecham and Childress, thinking about those goal-based and duty-based theories. As we sat down and discussed this particular situation, there was just this acknowledgement that we really wanted to help her. We wanted to promote her health. We wanted to offer relief, which is consistent with our principle of beneficence. We want to promote good. We also want to consider the options out there that are going to promote more good over harm. Also our obligations as providers. And so as a team, what are our obligations? Well, we weren't going to abandon this patient, even of her refusal of additional different types of care and the utilization of psychiatry. And it was evident that all of the diagnostic and treatment approaches had been taken and in fact exhausted at that point. We also didn't want to bring harm to this patient. We certainly didn't want the patient putting on pesticides on open wounds. And the fact that they had already purchased these things that were not only toxic, even in our home environment, but actually could do some significant harm. That was the first line of defense of, you shouldn't be using, don't utilize those. Those can actually be not just harmful, but an unnecessary treatment. Additionally, her demand of the biopsy, yet another biopsy, the provider sat down and said, I cannot continue doing biopsies because I am now at this point, this is not a process of diagnosis. This is not a process of trying to figure this out. I'm actually going to be doing more harm than good at this point. So again, that non-maleficence, beneficence, goal-based theories come up. We recognize the patient needed help and that there are standards of care, and we did not want to enter into the realm of abuse and neglect and abandonment of patients, but we also, standards of care were not necessarily at our fingertips. Parasitosis has a variety of different treatment options, including mental health counseling. And so it was still a suspected issue, but it was the number one on the differential after doing everything that we could beforehand. We also needed to be honest and not obviously lie to the patient. There have been cases of parasitosis where providers have been disingenuous in terms of patient care, where they're prescribing particular ointments, or they're bringing the patient into a clinical environment where there is a team and a psychiatrist is present, but they never disclose the fact that they're bringing mental health into the mix. And so when we're not being open and honest, that can also harm that therapeutic relationship. And patients often feel as though if they have capacity, if they're able to make their decisions, but yet they're not valued as autonomous agents, it can do damage to the therapeutic relationship. And then ultimately the patient has a choice to take what is offered and seek outside help or get a second opinion. And so that too was on the table from a general ethical principle-based approach. Now, given this laundry list of considerations, these options were actually placed on the table. We actually identify them as options in a quote unquote multiple choice approach. These were the options that our team had come up with. So do another biopsy, placate the patients. There's no underlying skin disease, would be a potential harm. Prescribe and monitor the use of cream, that the medication might help get rid of any bugs, but the fact that it was just going to alleviate some of the itching and the superficial symptoms at that point. Arrange a multidisciplinary consult, bring in psychiatry, dermatology, family medicine, and so forth. And, hoping that the patient would agree to that. Or prescribe Pimozide or another atypical antipsychotic and disclosing it, that this might be the most appropriate way to go through this. So just asking you guys, and your initial thoughts and initial exposure to just the fundamental principle-based ethics. What are your thoughts about this case? What options would you have considered? And what's missing from this case?
Well, we have incomplete information on this patient. What other medications is the patient on? Is she on any medication?
He was not on any other medications, but Pedro, that is a really important point, because when we get these situations in these cases, we want the whole story. And the whole story can be contained partially in a medical record, and it can be contained within the patient's support system or within themselves. And so whenever we are confronted with these ethical situations, we want the whole story. And a narrative approach, and we're going to be talking about narrative approach in ethics, is to get more information. So exactly, important step. What else?
Well, I'm curious, I would probably be interested in understanding the patient's beliefs and how they were developed around originally thinking they have this infection. Like what about their state makes them think they have it? Is it that they have other symptoms that we're not seeing that are making them think that? But then I know that by doing that, there's also the risk of making the patient think that we are not thinking their problem is medical. So then that is also another kind of subtle risk. But I feel like it's with a belief like this, it will be interesting or important to understand why the patient is holding it.
Exactly. And so, we want that additional information of when did this start? What were you experiencing in your life at the time when you started feeling this sensation? What is going on beyond just the physical feeling of having bugs or itchiness, etc. And so really delving into the patient's background, the psychosocial elements, the cultural elements. When did this originate and why is it continuing? Are there moments in her life that the flare-ups continue? So very much. Anything else?
I like the idea of, I was looking at option C with having a multidisciplinary consult, because to Pedro's point, there's a lot of information we don't know. And I know, years ago when I was in employment at a mental health agency, I remember having someone tell me that they were lactating and they thought they were pregnant, and there was zero possibility of it. And it was kind of, okay, all right. And then later finding out their medication, that was a side effect.
That was a side effect of medication.
Oh my goodness, I heard about this and I just did not connect it. And so having that multidisciplinary group to say, no, this could be a possibility, because that's the thing. I mean, especially itching, where once you, like, if we talk about lice, I will itch within 5 minutes. It's just the way it works. Like, you know what I mean? Like, I
So
know that I
true.
don't have it, you know, but like, it just, you know, that kind of stuff. And so even, you know, just addressing that kind of like surface level symptom might give that person a little bit of relief to then be able to talk about kind of the deeper issues that Chantel is saying.
Exactly. And, you know, it's because healthcare is so vast and people are specializing and narrowing their focus so much, we need to rely on a multidisciplinary team to really gain different perspectives and insights. And whether you're in social work, an ethicist, a dermatologist, a family medicine doc, coming together and saying, oh, I've either experienced this, I've read about this, I think this could happen as a potential side effect, or hey, I had an interest in public health. Let's explore the potential of bed bugs, even that you know have really have impacted many of our patients and clients in our community. And you don't always see them. You have to. I mean, there's dogs that will detect bed bugs because to the human eye, we're not necessarily seeing them. And so making sure that we have a multidisciplinary approach, or at least looking at a multidisciplinary approach from looking at the potentials for diagnostics is going to be critical.
Well, that's the thing too, even with from a client or a patient standpoint, like the amount that we don't know about perimenopause is staggering. And one of the symptoms is that you can be extra itchy. It's not even like from dryness, it's just like the itching like sensation increases. And you know, there are times where even like slight food intolerances or allergies that can, like, hours later when you're going to bed, can be the time that you itch, where people might think it's bed bugs and might think it's something else, but it's actually because you had tomatoes at 5 o'clock,
Right.
you know, so.
Yeah,
And I
so
think bringing in psychiatry too, or the mental health piece, I think can be explained to a patient in that, like, hey, this isn't necessarily because we don't believe you, but this is incredibly distressing. The idea of this going on, it just distresses me, and it's not even happening to me. So like, you could bring in those other team members as like, there's a distress component of this, and we just want to make sure we're helping you all the way around.
and it's a good approach, and we're going to start delving into the virtue care and narrative approach as the person-centered ethics, where by having that support system, not just for the patient, but also for the lone provider that may have exhausted all of their resources and you know their ability to think critically through this, especially when a patient is saying or refusing the additional options. So yeah, C and then potential D are the options that are out there, but those were never derived from the foundational principle-based ethics. So what we do know about the case, we have a therapeutic relationship. There are values of care, respect, even if providers are frustrated and you know just saying, I don't know what to do else. The healthcare is a team-based approach. Additional support, like I mentioned, for both patient and provider when welcomed and needed. Not all patients who have parasitosis are the same. And even when that is the ultimate diagnosis, there are, I mean, to Chantel's description, you know, we got to get to the bottom. We need that personal story and Pedro's perspective. We need more information. That's how we can offer better communication and caring, and then driving a better diagnosis while advocating for our patient. And then a provider who does recognize holistic care, the patient's personhood, their roles as duties as providers, having self-awareness, basically saying this is a challenging situation, not a challenging patient. And so how do we address the particular situation? And it may require going into public health perspectives, addressing the patient's home environment and going above and beyond. I hate that term above and beyond because that's what we should be doing. but it often takes more resources and more providers to quote unquote go above and beyond to find out how to best help this patient. And so when principles are not enough, we tackle this from a person-centered approach where we're looking at virtue ethics. We're looking at the traits, the character of the provider, whether they are going to be supportive of having a multidisciplinary approach, whether they're going to check the biases, the particular biases. The provider that believes this is parasitosis simply prescribes a cream, doesn't disclose to the patient what it's for, even if it's an antipsychotic medication, and doesn't disclose, isn't following that virtue ethics, that good approach to how we can achieve better therapeutic relationships and ultimately how we can flourish as humans. The two most recent person-centered approaches include care ethics and narrative ethics. And this care ethics originated from a feminist response to those doing theorists, basically saying, you guys are so rule focused, you're so principle focused, that the reality is that these situations are complex. We need to delve in to who's the support system for these patients. To Chantel's point of, where did this originate from? What was going on in your life when you started having these particular symptoms? Do you have the support system moving forward in the event the patient does recognize that there are no bugs, actual physical bugs, and that something else is going on? Do they have that support system going forward, including a clinical support system? There are various care elements ranging from making sure that an individual has the resources that they need, to making sure that if those resources are not being utilized to the fullest or they don't work, such as a particular medication, that a care approach is not giving up on that patient. And then the narrative approach, to Pedro's point, beyond the clinical record, beyond the medical record, what other medications is this individual on? What are her values? Does she have a particular stigma against mental health? Would she be amenable to having a comprehensive medical team? And consider that the fact that the itchiness, the open wounds, the resorting to pesticides and chemicals that could do harm, there is an emotional component here. There's a psychological component here that is not devoid of representation and consideration among healthcare professionals. So even talking to the patient saying, I recognize this is not comfortable for you, and I believe you, I support you, we're going to get to the bottom of this. Let's try these things that are going to possibly to alleviate that, because I can imagine this is emotionally trying, this is psychologically trying. You can't live like this, so let's get to the bottom of it. So these more person-centered approaches can help address. And for C and D, these are our options on the table. It's not, it depends on the individual. It's not this C's better or D's better, but for option C, as you guys have addressed, if she's willing to have a multidisciplinary consultant and bring in a variety of different people to support her, as well as the provider, this would be a viable option. It would also lead to gaining more information from her personal narrative, but also helping her recognize people care. And it's not just one provider that cares. If she's not amenable to a multidisciplinary consult, option D is a potential. The treatment may offer relief. We still have to utilize some of those foundational rule-based principles on weighing risks and benefits of different types of treatments, but to recognize that there's a physical and emotional psychological component here. And so by acknowledging the patient's feelings, where they came from, who they are, then also addressing some of the foundational principles. A care, virtue, and narrative approach can be folded into this option D. Okay. So the old traditional way of deliberating through cases such as this one would be presenting a case situation, whether you're on grand rounds, whether you're having a journal club, whether it's a situation that you're addressing to your team leads. We typically would present the case, what was in the medical record, what are the moral problems, what values are in conflict, and then we would throw these principles, right? These Beecham and Childers principles. Well, the reality is that we need more of the patient story because healthcare is so complex, and whether she has bed bugs at home that we need to address, or she has parasitosis, and we need to look at it more of a holistic perspective and have her on the same page. We do need to understand the needs, values, and goals of the patient, where she's at, what she's willing to do, and to strengthen those therapeutic ties. And so the old deliberative process that healthcare professionals, ethicists would take on ignored those three elements of virtue, narrative, and care ethics until we started calling out sometimes those principles don't always work. We can prescribe and say this is less risky, and end of story, but this patient would still be in distress. And so ultimately, when those final decisions are made, we need to go back, and it's not a linear process. We need to go back and continue to check, have those values, goals, and needs changed over time. And so that number 10, decision control consistency, legal public consistency. Decision control consistency also means going back and checking up on those patients' needs, values, and goals. And to do that is through not a principle-based approach, but more of a person-centered approach. So the bottom line, the questions that we ask are, is this an ethical issue? Are moral values in conflict? Is something else in play here? This was an ethics case only because the dermatologist that brought it to our attention said, I don't know what else I can do. I care deeply about my patient. She's not considering mental health aspects of this, but I think I'm approaching it in a wrong way. And so the dermatologist asked for support, asked for help on how best to navigate this very complex case. And after navigating this case through a variety of principles and traditional frameworks, it was recognized that the meaningful of that therapeutic relationship and getting the patient to recognize this is a complex disorder. We believe you. We know that you're going through these things. Otherwise, you would not have even these wounds on your skin. Was really important. And so not one theory approach fits all situations, but from an ethics standpoint, we need to start bringing more of this person-centered approach and not simply think ethics is about just basic rules to follow. Whether it's finding out more information, finding out who this individual is, what they're willing to do. And on the surface, it may seem like a no-brainer, but there are times where we're treating patients in such a fashion that we're diagnosing, prescribing, sending them on their way, and we might be missing some of these human elements. And healthcare is tough, and oftentimes you have limited time to go extensively through these particular situations unless the ethical considerations have risen. So, but that's our bottom line. Ethical deliberation decision-making ought to have these person-centered approaches. Unfortunately, still in healthcare education, nursing education, medical school education, we're so fixated on the four principles, even on board exams and everything like that, that we're missing out on really delving into these person-centered approaches. And they're quite extensive. Care ethics alone has a variety of different perspectives and processes, even within that care approach. I just gave you guys kind of a superficial overview of it, but to know that each theory, each approach is quite extensive in and of itself. Any questions? You guys want to add more to your analysis and anything else that might have been missing?